Dr. Vivek Gopinathan is currently the Associate Professor in Emergency Medicine, Kasturba Medical College, Manipal. He took his MBBS and MD General Medicine from Government Medical College, Thrissur, Kerala. He did his post-graduation cardiology from Johns Hopkins University School of Medicine. He has a teaching experience of 9 years. He is the American Heart Association Certified Hazardous Material Instructor and Course Director. He is American Heart Association Certified Instructor for BLS, ACLS, PALS, and ATLS. Also, All Indian Institute of Medical Science Certified Advanced Ultrasound Trauma Life Support Provider. We welcome you, sir, for your session.
Hello, good evening. Am I audible?
Yes, sir.
Yes. So, I am TOXOCON 14 for giving me this wonderful opportunity to make this presentation at your prestigious conference. Dr. V.V. Pillai sir, Girish sir, and my colleagues, Sri Krishna, it's so nice to see you guys. So we'll start with this session. So I'll be dealing here with the management of paracetamol overdosage. I'll be looking more into the aspects of the treatment part rather than more of the clinical features. Okay, so we'll just start with some overview. Okay, so acetaminophen. So in our part of the world, we call it paracetamol, but in the western part and countries like Canada, Japan, it's called acetaminophen. It is one of the most popular over-the-counter analgesics. And if you look at the kind of toxic exposures you get, it is now one of the leading causes of acute liver failure in the US. In India, I think it's still probably alcoholic liver disease, but within some period of time, it's going to be overtaking as the most common cause of acute liver failure. That's because of this, the ease of the availability of this drug. And usually we know that it is used both as an analgesic and antipyretic in our emergency department. Just coming briefly into its metabolism. So paracetamol undergoes around 85 to 90% of the glucuronidase sulfonation, which is the major pathway. And 10 to 15% of it undergoes the metabolic pathway through the NAPQI, that is the N-amino parabenzoquinone. So this is the metabolite which actually causes the liver toxicity. So you know, in our body, the glutathione, so it actually helps to conjugate and decrease the toxicity of this drug. But in the condition where glutathione is used, it lead to increased accumulation of the metabolite and causes the liver toxicity. Okay, so this pathway. Now, when do we actually say that it is an overdosing? So there is a certain guidelines for that. So when a patient over the age of 6 years consumes more than 10 grams or 200 milligrams per kilogram as a single injection, or more than 10 grams, that is 200 milligrams per kilogram over a 24-hour period, or greater than 6 grams or 150 milligrams for 24 hours in 2 consecutive days. So when such a dosage is there, it culminates to an overdosage. Now in children less than 6 years, an injection of 200 milligrams per kilogram as a single injection over an 8-hour period, or 150 milligram per kilogram for 24 hours preceding 48 hours is also considered as an overdosage. So there's a guideline for that actually. But the important thing what we want to stress on is that the even if you take in such a dosage, because of some kind of metabolism or the kind of food we eat or other drugs, it is actually the level, the serum level of acetaminophen concentration, which makes us go through the therapy and the clinical signs and symptoms. So just because they eat this much, we don't go for treatment. It is the clinical signs and symptoms along with the serum acetaminophen level, which prompts you to go for the treatment. Okay. Now, there's also a term called massive acetaminophen dosage. That is, if you're consuming more than 500 milligrams per kilogram. So if it's a 60 kg person, 500 milligram means around more than 30 grams, or definitely more than 40 grams per a single dose. It is called a massive acetaminophen overdosage. Now I'll just come to the concept of this Rumack-Matthew normogram. So most of you have heard it. So what is this thing actually? So here it is a graph plotting the concentration of the acetaminophen versus the time you have consumed. And you can see there's a normal line. There's a normal line. If your serum concentration of acetaminophen, the one you test post 4 hours, is above this line, it warrants that the patient can go in for real hepatic problems, and you have to look in for many complications. So that is the implication of this. So once you get a 4-hour or post 4-hour acetaminophen value, you can actually do this. You can plot the graph and look if this is going to go for a hepatic damage. So that is the importance of the Rumack-Matthew normogram. Now, I'll just come to some of the principles involved, or what are the methods we have for the management of paracetamol overdosage. Now, the first one is the gastrointestinal decontamination. Nowadays, people are a bit skeptical about the lavage, but what we usually use is activated charcoal, right? The administration of activated charcoal, it actually has shown to decrease the number of patients who have actually gone into severe treatment. And it is most useful when it is actually given 1 to 2 hours within the ingestion. So an early presentation along with an early administration of activated charcoal is actually very useful. And even if a person presents late, there is no contraindication in giving the drug. But early presentation with an early starting of drug is almost always warranted. And the usual dose we give, I think to keep it constant among children and adults, we'll take it as 1 gram per kilo. Yes, activated charcoal, we see this usually. It's taken, crushed, made into a powder, and it's given through the routes too, right? Now, another point of discussion they brought about is that, like, suppose you are giving it post 4 hours. So now post 4 hours, the problem is that you usually start N-acetylcysteine, which is one of the main antidotes in paracetamol poisoning. So this actually prompts you to give the early, activated charcoal, because in the later half, if you're giving an oral NAC, it actually can, hinder your administration. But they say that you can space the administration. You can first give the, activated charcoal, wait for 1 to 2 hours, and then give the N-acetylcysteine. Okay. Now coming to the main antidote. So the main antidote we have over here is the N-acetylcysteine. So like I showed in the metabolism, so this N-acetylcysteine, it's a very important drug. It's considered the antidote, and it prevents toxicity. How? Because it prevents the formation of the NAQPI. So that itself is important. Secondly, the glutathione, like we said, the glutathione, which is used to detoxify NAQPI, is actually depleted during the paracetamol poisoning. Why? Because it's used up. So this over here also helps to replenish the stores of the glutathione. And in the third part, they say that the cell injury inflicted by the metabolite is also reversed by the N-acetylcysteine. So if you look at it, you can see it as almost an antidotal drug for paracetamol poisoning. Yes, we have 2 forms which is usually available, that is the oral form and the IV form, right? Now, what are the dosing that we usually use for the oral form and the IV form? So this is very important. We see a lot of cases of paracetamol poisoning. So this is a very standard thing. I have used it from Tintin Alley, which is one of the best recorded documentations of the use of N-acetylcysteine. We have an oral dose which starts off with a loading of 140 milligrams per kilogram. So the loading dose is 140 milligrams per kilogram, followed by we give a 70 milligrams per kilogram every 4th hourly for 17 doses. So the entire duration of therapy is 72 hours. So 140 milligram per kilogram followed by 70 milligram per kilogram. This is the oral dose. Now coming to the IV preparation. So it's almost the same, a little difference, but over here there is a three segment regime. So we start off with a loading dose of 150 milligram per kilogram of N-acetylcysteine. It's usually given over a period of 1 hour. And after this 1 hour, we go for the next 4-hour therapy, which is 50 milligram per kilogram. And once the 4 hours are over, then we go for a 16-hour therapy with the same 100 milligram per kilogram. So the total dose of total duration over here is 1 hour loading dose, 150 milligram per kilogram, 4 hours, 50 milligram per kilogram, and then the next 16 hours of 100 milligram per kilogram, which amounts to 21 hours. Okay. Now, is there any side effects of N-acetylcysteine as such? Because it's a drug. So not very severe complications have been mentioned, but in some, there have been like few anaphylactic reactions and some medication errors and all. With the oral dosage, one thing common is vomiting. Other than that, no other side effects for the drug per se has been documented. Now, oral versus what you say IV. We usually go for an IV dose more frequently, only in the case where these three scenarios where it is generally very much warranted is that where there is a pregnant woman with paracetamol toxicity, or where there is a induced paracetamol induced hepatic failure, and any condition where there is prevention of oral treatment. For example, the person has got a perforation, could not swallow or something like that. In that conditions only, we go for an NAC, that is the intravenous NAC. Now, the next treatment modality which we use is hepatic transplantation. So the hepatic transplantation, it has shown to actually increase the survival of people. It is not very common. It's very a procedure which has got a lot of cost into it. But for those who can afford, for young people, now this option, especially with many centers having an integrated gastroenterology department, so this is one very good option we should provide for the patient. Now, what are the criteria which predicts whether the patient will go for a hepatic transplant? So this is called the King's College criteria. This is basically clinical criteria. So if you have an arterial pH more than 7.3, which shows that there's a severe acidosis, or a lactate more than 3, or you have all of these criteria, that is where you have got a creatinine more than 3.3, a severe prothrombin time more than 100, or a grade 3 or 4 encephalopathy. So this is the King's criteria which warrants that this patient will eventually end up having a hepatic transplant. The King's criteria. Now coming to some new modalities, ECMO is there, the extracorporeal membrane oxygenation system. It's an extracorporeal method. We had a case where we could use an extracorporeal elimination system over here in our Kasturba Medical College. Unfortunately, the patient died, but it was a good attempt. We made a good attempt. And this patient had gone into stage 4, very severe hepatic failure. What are the conditions where you can use it? One, when there is an altered mental status, when there's a very severe metabolic acidosis, when there's an elevated lactate, or there's an acetaminophen level, a serum level more than 900 milligrams per liter. So these are the conditions where we can go for an ECMO. Now, the other modalities, hemodialysis, as we know, one of the most commonly used thing. So you can go for a continuous method, the a continuous veno-venous method, and usually we have find that people who have been using N-acetylcysteine, there's a problem when they go hemodialysis. What happens is that this N-acetylcysteine, which is an antidote, is also removed along with this hemodialysis. So we should step up the dosage of N-acetylcysteine in such patients. The newer modalities, like Senthil sir was saying, the plasmapheresis, plasma exchange methods. So for patients with acute liver failure, patients with coagulopathy, all these things are useful. The newer methods, just to mention them, so that in coming times, this can be actually useful. And a last thing which I wanted to say is that there is a new concept, which is known as, we have heard of renal dialysis. So something known as liver dialysis coming up. It's there in the Western world. So I just feel it's a matter of time and it's just going to come here. So they have got some methodology for that. So it's called the extracorporeal albumin dialysis. They use a molecular adsorbent and they do the dialysis. This is to cleanse the liver, they say. And another thing is the fractionated plasma separation and adsorption. and then the single pass albumin dialysis. So these are new methods. Just to mention the names, you might hear this in the future, but these are coming up modalities for the treatment of paracetamol poisoning. Okay. Now, I just put a timeline-based management. So when a patient is presenting to you in the emergency department, so how do you go about it? So I just put like the first hour. So as soon as the patient comes, so what are the important things that you look at? Definitely, we always go by the same algorithm. Look at the airway, breathing, circulation, disability, and exposure, the ABCDs. Look whether the patient needs to be intubated. Look how is his chest. Has he vomited, aspirated? Look at his pulse BP. Look at his neurological disability level and see if there's something in the exposure. As soon as you do that, you put a large bore IV cannula, draw blood for the basic investigations, right? You go for the blood glucose, the complete hemogram, including the PT, APTT, go for a liver function test, renal function test. Also draw a sample for the paracetamol level. Now, the thing is that we do not know at what time they consumed, even though they claim. We always say take an early sample of the paracetamol level, and because that can be a determining factor in deciding how far you should push your treatment to. Also, the next thing you can do is that put in a Riles tube. The older days where we used to give a stomach wash, I don't think we are doing it now much of this, but we could aspirate a sample and always keep a sample for toxicological analysis. You know why? It's very important, you know, the importance of MLC, which is coming up nowadays. So aspirate a sample and keep it for the stomach contents. Early start activated charcoal. The dosage, what we said was 1 gram per kilogram. Immediately start off with the N-acetylcysteine. You can go for an oral dose of 140 milligram loading dose, or you can go for an IV dose, like we said, the initial 150 milligram per kilogram. Catheterize the patient, send for a urinary tox screen. Okay, plot the chart and see whether this patient will end up having a liver pathology or might go into a hepatic failure. Take an EBG, like we said, look for the metabolic acidosis, immediately do an ECG and echo and keep the values ready. Now, the next stage is where we can go for the 1 to 6 hours. So after you have quickly initially gone to the patient, seen the person in detail, go for a 1 to 6 hour module. Over here, the important thing is the sample history. You should get the details, like what was the time and date of the consumption of this, because you know I have seen a lot of cases. They say on 15th, and this 15 has been misinterpreted with the time 5:15:00. Date becomes 12. It becomes 12 a.m. So complete change, and you know the importance of documenting the MLC. So get a very accurate date and time, the exact amount consumed, the place of consumption, the cause of consumption, what is the route? Was it an oral route? Was it an IV route? Was it injected? So get the route of exposure, the suspected material, if possible, ask them to bring a sample, ask them to show what material they had, ask the relatives or bystanders to get what was the thing, and also the dosage. In the second phase, we can go for a detailed secondary examination, look for all the clinical features, look for features of chronic liver disease, and we can continue the N-acetylcysteine, which we started in the first hour, because over there we have finished the initial dose, and you can go over to the next dose where you are giving the loading for the 4th hour, which can be continued. Also, never miss, important, take a chest X-ray, do a USG abdomen, and if there is a plan for hepatic transplantation, we know that as emergency physicians, we'll have to detail it and explain it early, involve the gastroenterology team. If there is a need for hemodialysis or plasmapheresis according to your center, please do it. But very, very important, always make sure you are documenting an MLC. So there is no doubt about it, it will go for an MLC documentation. So this is the first hour and in the 6-hour regime. Post the 6 hours, depending on the capacity of your institute, you can either shift to an ICU or you can keep under observation. So that is individualized. Now I just put a chart detailing like how you should go about it, like post the paracetamol ingestion. So if a person is presenting early, that is within 4 hours of the ingestion, consider a quick GI decontamination. Send for a level, and if the levels are available, plot the nomogram and see if you need activated charcoal treatment, or if it's not, just go for a symptomatic treatment. Now, between 4 to 24 hours, always now the person has come within the after the 4-hour window. So you can always send the paracetamol level, and the same, you follow the same algorithm. Now, if it's above 24 hours, don't wait. You immediately consider the GI decontamination, send all the investigations, including the liver function test, everything, and take a call whether you have to immediately start treatment, refer for the unit, gastroenterology unit, and plan for a hemodialysis. So I think this is in short the quick approach to the management. Over here, we usually have tablets of 400, 600, or 650 or 500 milligrams. But there is something known as multiple release tablets. So this is something new. It's not there in our place. They are actually bi-layered tablets. So initially, there's a release of 125 milligram, and then later, maybe after an hour or after some more time, there is a release of another 125 milligram. So what is the relevance of this? So the thing is that when you take the first value, it might be low. It might be in the second value. When you take again, actually it rises. So there is a, what you say, a multiple bi-layered kind of multiple extended release tablets, which is also available. So look into that also. But with the treatment aspect, there is no change. As per the patient's clinical signs and symptoms and the laboratory values, we treat the patient. Yes, I think with that, we have come to the end of this. I thank you.
Thanks, Dr. Vivek. We'll check for any questions. There is a question from Dr. Wilson. It's a very clear question.
Yes, sir.
Just a minute. Yeah, very clear presentation, Dr. Vivek. There is a simple dosage schedule followed in PACU advised by Frank Shah, intensivist from Australia. Loading dose of 150 mg per kg IV infusion over 1 hour and maintenance dose of 10 mg per kg per hour for 48 to 72 hours. Adjusted by clinical and biochemical trend. I request your comments on the same.
Yes, sir. Yes, sir. So I thank you, Tankavelu, sir, for that sharing the light on that. So lot of genes are there, and I feel as per your institutional or your center's protocol, you can stick on to. I have seen a lot of definitions, lot of protocols coming out, and I don't think one is superior to the other or one is inferior to the other. But whichever you follow, whenever you're for the purpose of either for the purpose of MLC or any purpose, you have to document that I have done so and so because of such a protocol. Anyway, thank you, sir, Tankavelu, sir, for giving that, sharing that knowledge.
Thanks. I have a question for you. It's also regarding NAC only. So even though, even though the protocol says oral NAC, we are all so much conditioned to feel that the IV is always better, and what if the patient vomits after giving oral NAC at all? So do you have any experience with oral NAC?
Yes. So actually, I was saying the same thing. In early presentation, there was one reference I put across, I think. And early presentation, the edge of oral versus an IV is not there. Both almost have the same kind of efficacy. But as the time passes by, and as the hepatic or the other features set in, a little more edge with regards to the IV N-acetylcysteine was there. It was there in one of the references. If you want, I'll just put it across. So I think if it's an early presentation within 4 hours, even though we are accustomed to giving IV, there is not a very much edge of oral or IV. But later, after 4 hours, I feel the IV is more better. This is one or two of the research articles I've read.
Thanks, Dr. Vivek.
B.V. Pillai, sir? Any comments on the same?
I think I just have one small comment, sir, and that is, yes, I agree there are a profusion of protocols of late with regard to paracetamol, and sometimes that causes a little bit of confusion. Maybe I would say a standardized, protocol that is acceptable to a majority of the physicians and pediatricians in India would be nice, because that will avoid confusion. I know that there are protocols which question previous protocols and things like that. After all, this is an evolving kind of field, and whatever is the consensus at present, maybe we can follow that. I would like your comments on that.
True, sir. I feel we can formulate if there is a thing we can formulate. Indian data is a bit less on the paracetamol dosing exactly. So I think once we have adequate data on that, we can do that.
Thank you, Dr. Vivek, for a very good presentation. Thanks a lot.
Thank you, sir.